Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Still on our discussion of diffuse lung diseases. Today we're going to be talking about antigen and exposure related lung disease. Now, most inhalational lung diseases predominantly affect the upper lobes because the lower lobes have a more robust blood flow and lymphatic drainage, and so usually if any foreign thing comes into the lower lobe, it's easily drained away. However, because of the limited blood flow and lymphatic drainage to the upper lobes, and also because of the increased aeration of the upper lobes, you have inhaled things floating more towards the upper lobes and staying there because they're not being drained away. Now, we'll start with hypersensitivity pneumonitis. Hypersensitivity pneumonitis is a common lung disease that is caused by hypersensitivity reaction to inhaled organic antigens. Now, the key word here is organic antigens like bird proteins or thermophilic actinomycetes. Although most of the time, let's say a third of the time, patients would not report having exposed themselves to some antigen. Hypersensitivity pneumonitis is characterized by two clinical causes: acute/subacute and chronic. Now, the chronic one has progressive symptoms. You may or may not have acute exacerbations, and there's also fibrosis as a result. The acute/subacute one may have recurrence but no fibrosis. So the presence or absence of fibrosis on imaging helps you differentiate the chronic from the acute or subacute one. So into a little more detail, the acute or subacute variant is characterized by inflammatory exudates filling the alveoli. And once we start talking about things filling the alveoli, that would mean that on imaging, it would manifest as non-specific ground glass or consolidation, depending on whether the alveoli are partially or completely filled. You may also have small, ill-defined centrilobular nodules, and ground glass can also be seen. Also, because of the inflammation affecting the airways, you could have mosaic attenuation that can be secondary to mosaic perfusion on inspiration and air trapping on expiration. The chronic hypersensitivity pneumonitis is from long-term exposure to the same offending antigens that we have mentioned earlier, and this leads to pulmonary fibrosis. Typically, it affects the upper lobes predominantly, but that's not always the case. You might also have the findings of acute and subacute disease superimposed on the findings of chronic hypersensitivity pneumonitis. The symptoms that a patient with chronic hypersensitivity pneumonitis would have would follow a chronic progressive course, or you may have multiple exacerbations. But whatever the case, the imaging would always show fibrosis, and this fibrosis is typically peribronchovascular. Another sign that we may see is the head cheese sign, and that describes the combination of patchy ground glass and areas of lucency due to the air trapping. So you're going to have ground glass attenuation, you're going to have the very lucent areas as a result of air trapping, and then you're going to have normal lungs. So that gives you three different densities. So it is these three different densities that come together to give us the head cheese sign. I'm sure it's describing something called head cheese, which has three different densities, I guess. Now, unlike idiopathic pulmonary fibrosis, where you have honeycombing, in chronic hypersensitivity pneumonitis, you don't have honeycombing. But if this honeycombing is present, you will mostly have it in the upper lobes, as opposed to its predominance in the lower lobes in IPF. Then to pneumoconiosis. Now, pneumoconiosis is a lung disease secondary to inorganic dust inhalation. That's in contrast, hypersensitivity pneumonitis, we mentioned, is caused by organic dust inhalation. So the first ones we'll talk about are silicosis and co-workers pneumoconiosis. And these are the two most common pneumoconiosis. They actually have indistinguishable imaging findings, even though they are due to different inhaled dusts, and they have different histologic findings, but on imaging they look very similar, and some of their imaging features also overlap with sarcoidosis. Silicosis is due to inhalation of silica dust, which miners may be exposed to, and co-workers pneumoconiosis is caused by inhalation of coal dust, which does not contain any silica. The most characteristic finding of uncomplicated disease is multiple upper lobe predominant perilymphatic nodules. Remember, we mentioned that most of the inhaled diseases would affect the upper lobes, right? Then sometimes you would have eggshell lymph node calcifications, and these are commonly seen in silicosis and less commonly in co-worker pneumoconioses. Silicosis or co-worker pneumoconiosis can become complicated with large conglomerate masses or progressive massive fibrosis when most of the opacities then coalesce. It's important to also remember that both silicosis and co-worker pneumoconiosis confer an increased risk of tuberculosis. There's a syndrome called Kaplan syndrome. It's seen in patients with rheumatoid arthritis and either co-worker pneumoconiosis or silicosis. So you have rheumatoid arthritis plus CWP or silicosis. Most commonly, it's CWP. And it represents necrobiotic rheumatoid nodules superimposed on the smaller centrilobular and subpleural nodules of the pneumoconioses. Now to asbestosis. Asbestosis is a lung disease caused by inhalation of asbestos fibers. The end stage of asbestosis can lead to pulmonary fibrosis with a UIP pathology. Remember in the previous discussion, we mentioned that UIP, usual interstitial pneumonia, is a pattern, a histological pattern. And so one of the causes of UIP is asbestosis. Unlike the other inhalational lung diseases, asbestosis predominantly affects the lower lobes. Yes, I know I mentioned that the inhalational diseases mostly affect the upper lobes, but hear me out. Asbestosis would affect the lower lobes predominantly because the asbestos particles are too large to be removed by the alveolar macrophages, and so they are heavy, they get down into the lower lobes, and the alveolar macrophages can't take them out, and so they stay in the lower lobes and cause disease in the lower lobes. The radiographic or the CT appearance and distribution of advanced asbestosis may be indistinguishable from idiopathic pulmonary fibrosis. However, an important clue seen in asbestosis is pleural thickening and pleural plaques. Yes, you would see pleural thickening and pleural plaques in asbestosis, but that doesn't mean that these pleural thickening and pleural plaques are actually a component of asbestosis. This is because these pleural plaques can be present without the pulmonary components. The plaques only tell us that a person has been exposed to asbestos, and having the plaques doesn't mean that you have asbestosis. It just means that you have been exposed to asbestos. It doesn't lead to fibrosis, and it's usually asymptomatic. So you can see a chest x-ray or a CT with only the pleural plaques without the pulmonary disease of asbestosis. That just tells us the person has been exposed to asbestos, but doesn't mean the person has asbestosis. I hope that makes sense. So these images are images of a person who has silicosis complicated with progressive massive fibrosis. So this CT demonstrates upper lobe predominant fibrotic changes. You can see some here, and there are also perilymphatic nodules here, pointed to by the yellow arrows, and a developing left upper lobe conglomerative mass. You can see that here. You can see a mass is actually developing here. That is the developing progressive massive fibrosis in a patient with silicosis. In the mediastinum, we can see some eggshell-like calcified lymph nodes. These peripherally calcified lymph nodes here. Now, for a little bonus, we'll talk about eosinophilic lung disease, which is a spectrum of diseases that feature accumulation of eosinophils in the pulmonary air spaces and interstitium. Now, that should tell us that we can't just look at the chest x-ray or CT and call it eosinophilic lung disease. We must have proof that there are actually eosinophils there. Aside imaging, eosinophils are cells. We can't look at imaging alone to tell us that those cells are present. All right. So we'll first talk about simple pulmonary eosinophilia, aka Loeffler syndrome. Simple pulmonary eosinophilia is characterized by transient and migratory areas of focal consolidation with an elevated eosinophil count in the peripheral smear. So you realize that you have to have a smear to tell you that you are seeing eosinophils, and then you add that to the imaging features and then come to your conclusion of simple pulmonary eosinophilia. Now, the fact that we are also calling it transient and migratory tells us we need more than just one image. You would need prior images, you need follow-up imaging to follow the course, and then you can confidently make your diagnosis of simple pulmonary eosinophilia or Loeffler syndrome. An identical appearance can be seen as a response to injury, especially with parasitic disease and drug reactions. So you can have some drug reactions and parasitic disease that would give you a similar picture, but you would only call it simple pulmonary eosinophilia if you have an idiopathic case. Now, chronic eosinophilic pneumonia is an important consideration in the differential diagnosis of chronic consolidation. Chronic eosinophilic pneumonia causes extensive alveolar filling and interstitial infiltration with inflammatory eosinophils. Consolidation is patchy and peripheral with an upper lobe predominance, and this gives us the appearance of something we call the reverse bat wing configuration. So in pulmonary edema, we mentioned the bat wing configuration where you have more centrally located consolidation. However, in this case, it's reversed. So it's rather the periphery that are consolidated, and then the central part may be normal or less consolidated. Furthermore, consolidation may cross fissures, and that helps differentiate it from cryptogenic organizing pneumonia. Chronic eosinophilic pneumonia is also much less common than cryptogenic organizing pneumonia. You have to compare to prior films for transient or changing infiltrates over time, just like I mentioned with simple pulmonary eosinophilia. Chronic eosinophilic pneumonia responds rapidly to steroids, but unfortunately, relapse is also very common after you discontinue the steroids. Patients almost always have peripheral blood eosinophilia. So in this image, it's an axial CT, and it shows bilateral patchy peripheral consolidative opacities. Of course, a peripheral smear would be needed to finally clinch the diagnosis of chronic eosinophilic pneumonia. And again, this should have been present for more than 6 months to indicate its chronicity. Thank you very much for your attention. The next topic we'll be talking about 2 topics actually: pulmonary vasculitis and iatrogenic lung disease. I hope, as usual, you are finding value from this. If you are, give it a like, share, comment, and subscribe if you have not yet subscribed. I will see you in the next one.